Hi, very good morning. I'm Dr. Janak Patel. I'm MD General Physician. I'm not a neurologist. I'm still a student. Whatever knowledge I've gathered till today, we'll be discussing and I'll be sharing with you. Today, we'll be discussing on a very interesting topic which you will see in your everyday practice, that is altered level of consciousness, or we call coma or unconsciousness, or also sometimes we use an odd term which is not fitting with is altered mental status. So we'll be discussing on that particular part, altered mental status, or we use the word coma, or altered level of consciousness, or we use the word unconsciousness, etc. We'll be discussing under the heading introduction, terminology, etiology, then how you approach, how you examine a person, investigations, treatment, a general treatment and specific treatment, and complications. So first let us go through what is consciousness. Consciousness is defined as a state of full awareness of self and one of the relationship to the environment. What is the meaning of that? Means person is alert, awake, or you use the word arousal. So whenever a person is alert and awake, he is fully oriented, or we call he is aware of time, place, person, object. That is we call environment. So whenever a person is alert or awake and he is aware, or we call oriented, we call that person is conscious. While coma is described as a prolonged unconsciousness, means if these two things are affected, person cannot be aroused and person is not aware, then we call that as unconscious. So coma is a prolonged unconsciousness. Also, it is a very simple way to describe. There are a lot of different ways of description. It is a persistent state of unresponsiveness. Here person is responding and there is a total absence of arousal and awareness. Means both of these are totally absent. Then we call that a person is unconscious or he is in a stage of coma. There is another way of description also. Coma is a state of complete behavior unresponsiveness to external stimulus. See here, it is not mentioned regarding awareness. So coma is a state of a deep sleep where the person is to be in a profound state of unconsciousness, cannot be aroused or cannot be awakened, fails to respond to normal painful stimulus or a light or a sound. There is no sleep-wake cycle. There is no voluntary action, and person is in a state of a coma, or we use the word comatose. So this is a long thing. So this is a very simple way. It is a persistent state of unresponsiveness, means person is not responding, and there is a total absence of arousal and awareness. A very simple and complete definition. Now, sleep we have already described. So, in a coma, person is not arousable and he is not aware. Syncope, concussion, is a short lasting. So, that is described as a transient alteration in level of consciousness. Transient elation. Transient alteration in level of consciousness. So it is transient unconscious, like syncope, concussion, and coma is usually which lasts for a longer period. So it is lasting for a longer period. So if there is a transitional state, then there are two types. One we call as a vegetative state, and another we call as a locked-in syndrome. And there is another term which is commonly utilized is brain death. We'll be using that term later on. So sleep is an active process, but we describe as reversible state of unresponsiveness, and person can be easily aroused by external stimulus like sound, light, touch, vibration, smell, superficial pain, temperature, etc. And after arousal, the person is fully awake and is fully oriented in time, place, person, object, etc. Now you can see these are the two people. This is less likely to be conscious, because if the Ryle's tube is here, if this is inserted, that is tracheostomy is done, and person is still in a sleepy stage, this person is bound to be unconscious. Well, this can be sleepy or can be unconscious. So you will have to examine a person and decide whether the person is in a stage of a sleep, and if he is having altered level of consciousness, what is the level of consciousness. You can see here there is a stimulus which is coming from different parts of the body to the brain stem. It activates the ascending reticular activating system, we call ARAS, ascending reticular activating system, which will pass on the impulse to hypothalamus, thalamus, surrounding structures, and then to cerebral cortex, which makes you awake, and cerebral cortex will be giving you answer regarding environment. So once the person is aroused, he is fully oriented. Now you can see some of these people. These people looks to be confused, and these are always confused. These are always confused. So coma is a state of impaired consciousness in which the patient is not arousable despite of external stimulus. These people are also not arousable by external stimulus. They are always confused. So right from confusion, person can go into a stage of delirium, can go into a stage of stupor, and can go into a stage final where person is not arousable and is not aware. That we call as coma. So from alert, lethargic, or we call drowsy. From drowsy, confusion, in between, this will be confusion, in between delirium, then stupor, and final stage will be coma. These are some of the people. Again, we can use then another term we call as altered mental status. Typical confusion, this is delirium, he is getting illusions. These are all confused people. This is also altered mental status. This is also altered mental status. So there should be always one question: are you unconscious? For that, a very simple thing: say is fully conscious, because a conscious person can stand, unconscious person cannot stand. Now this is most likely to be unconscious, this is also most likely to be unconscious, this is likely to be in a sleep stage. So you have to identify whether he is in a sleep stage, is unconscious, or is conscious. This person is conscious, or these two are unconscious, or we use the word comatose. So let us first understand why a person becomes. So for understanding that, you can see there is a constant stimulus from this ascending reticular activating system to a cerebral cortex via thalamus and hypothalamic region. These are all the different area: thalamus, subthalamus, hypothalamus, midbrain region, etc. They are activated first by ascending reticular activating system, and that ascending reticular activating system is getting an input by a sensory tracts from different parts of our body, and they activate what we call as a cerebral cortex. So cerebral cortex is constantly stimulated and person becomes awake, or we call alert. So you need three systems. One, sensory system, which is activating reticular activating system. Then you need a reticular activating system, which is ascending reticular activating system. You need nucleus like hypothalamus, thalamus, and paraventricular nucleus, and you need cerebral cortex. So these are all the different structures which are required to maintain your consciousness. So if there is anything which damages reticular activating system, brainstem region, which is consisting of this ascending reticular activating system, or you get damage to hypothalamus, thalamic area, and paraventricular nuclear areas, if you get damage to those portions, or you get damage to cerebral cortex but bilateral damage and extensive damage, then you will have altered level of consciousness. This damage can be because of infection, trauma, vascular tumor, hydrocephalus, or maybe because of extracranial pathology. And all this pathology can produce compression or may produce destruction. Destruction can be because of trauma, infection, vascular, tumors, etc. And compression will be very commonly because of tumor, hydrocephalus. Very rarely because of SOL following brain abscess, following bacterial infection, or hematoma in case of a trauma. In a case of a vascular intracranial hemorrhage, you can have a hematoma which can act as SOL, producing compression as well as destruction. Or extracranial causes, it can be metabolic disorders, temperature, sodium, electrolytes, etc. So we divide those particular into extracranial and intracranial. Extracranial will not produce by and large compression and destruction. But among extracranial, hypoxia can produce ischemic damage to brain cells, leading to cerebral edema, and which can produce compression and destruction both. But by and large, other groups like sodium, calcium, magnesium, alcohol, they do not produce compression. They can produce destruction. So this is the pathophysiology which you should understand. You can see here, there's a small collection of blood clot. We call as extradural hematoma, and that will produce a compression of the brain. Persistent compression of the brain will produce destruction, and then because of this pressure, increased intracranial pressure, it will start producing pushing of the brain, we call herniation. So because of intracranial pathophysiology, very frequently you will have a raised intracranial pressure, and secondary to that, mass effect, and you can have a herniation. This is uncal herniation. This will be, so this is subfalcine herniation. This is uncal herniation. This is central herniation, and then you get cerebral herniation or tonsillar herniation. Now, to find out what stage it is very, very important. So, very simple test what is being done is AVPU. So, we label that as alert, verbal response, response to painful stimulus, and unresponsive. Say if a person is fully alert, means he is awake and he is fully oriented. then we call that person as an alert. But say person is sleepy and he responds to an external stimulus like verbal response. But as soon as that stimulus is withdrawn, person goes back to sleep. That we call as a drowsy stage. Further advanced, person is in a sleepy stage, he is lethargic, he responds to verbal stimulus, and now he is not aware of surrounding, he is disoriented. Usually word utilized is obtunded, while in a drowsy state, majority of the time he is oriented. But as soon as that stimulus is withdrawn, the person goes back to sleep. That is drowsy stage. Now, if a person is not alert, he does not respond to verbal stimulus or other external stimulus. But as soon as you give a deep painful stimulus, person is aroused, but he is disoriented. He obeys some of the commands we call stupor. But if person cannot be aroused by deep painful stimulus, we call unresponsiveness. And if a person cannot be aroused, he is not aware of it. So there is absence of arousal and there is an absence of awareness. And deep painful stimulus you can give by pressing over the manubrium, sternum, nail bed, supraorbital nerve, TM joint, nasal septum, ear lobule, etc. All these are very painful. And if a person does not respond to that pain, we say usually the person is in a stage of coma, or we call comatose patient. But if he partially responds, stupor. And if he responds to verbal stimulus, drowsy or obtunded. And he doesn't require, he is awake and he is aware, we call that as alert. So grading wise, they are divided into grade 1, grade 2, grade 3, grade 4, grade 5. Grade 1 is nothing else but close to sleep, we call as conscious. Grade 2, we call drowsy. Grade 3, we call stupor. Grade 4, we call comatose. And grade 5, we almost call as deep coma. The difference between comatose and deep coma is, in a comatose person, when a painful stimulus is given, a person gets decorticate posture or a decerebrate posture. Decorticate is flexion, decerebrate is extension. And in a deep coma, person will have a flaccid stage, or we call unresponsiveness to even deep painful stimulus. Then we call that a person is in a stage of a deep coma. It is a bad sign. So we have already used the words consciousness, confusion, drowsy, stupor and coma. Now little bit again regarding a confusion. Confusion means person is fully conscious, he is alert, he is awake, but he is fully oriented, but he talks irrelevantly. While drowsy is person is sleepy, he can be aroused by external stimulus, and after arousal, by and large he is always oriented, and as soon as you stop an external stimulus, he goes back to sleep. While in a stupor, he is in a stage of a deep sleep, cannot be aroused by an external stimulus, but can be only aroused by painful stimulus. And as soon as you stop a painful stimulus, person goes back to deep sleep. This is stupor. And coma, already we have told you, no response to external stimulus. Even a deep painful stimulus, no response, means you cannot arouse. And once he is not arousable, he is unaware. And there is one term we use is delirium. So delirium is a stage of confusion, is disoriented, plus very important part, he gets hallucinations. So if any person who is little confused, who is disoriented, and is having simultaneously hallucination, we call that as delirium. These are the different altered level of consciousness we use in our everyday practice. And coma we already described persistent state of unresponsiveness, total absence of arousal and awareness. These were all the terms which are now outdated: lethargy, obtundation, minimal conscious state, akinetic mute, locked in syndrome. These are some of the things you must be aware of it, and you should be able to differentiate from altered level of consciousness. There is one word called as a vegetative stage, in which person is unaware of self and environment, but he has got brainstem reflexes preserved, and it is usually after 3 months of non-traumatic injury, and that we describe as a vegetative stage, in which person can be aroused, is awakened, but is unaware of self and environment. So that is described as a vegetative stage. What is brain death? Brainstem reflexes are absent. There is an irreversible comatose stage. It can be detected by, it can be confirmed by EEG. You can have evoked potential test. You can have clinical examination. And if the person do not have any brainstem reflexes preserved, usually we term that person as a brain dead. This is one chart which is showing you in relation to arousal and awareness. In a normal conscious person, both are completely normal. In a coma, in a sleep, or during anesthesia, both are at the bottom. So, very simple way to differentiate between coma, sleep, and anesthesia. In a sleep, person can be aroused and aware on stimulus. During anesthesia, person cannot be aroused, cannot be aware. And even in a coma, person cannot be aroused or cannot be aware. In a vegetative stage, person is arousable, but he is unaware of self or surrounding. And in locked in syndrome, person is arousable, he is aware, but he does not have a motor movements. That is typical locked in syndrome, because there is a damage to brainstem. So cerebral cortex is working, but brainstem has been locked. So cerebral cortex do not have a control on lower limbs. That same thing what has been shown here. So if a person is arousable and aware, it is anxiety, lethargy, locked in syndrome, or normal person. Normal person we already shown you here. A normal person, or we call conscious. A person is arousable but is unaware. Classical example: delirium, dementia, psychosis, and vegetative stage. And person who is cannot be aroused, is not aware, coma and brain death. So I have already given you that particular answer. But there is one typical word which is being utilized for vegetative stage, is aroused without awareness. And if it remains more than 1 month, then we call it a persistent vegetative stage. And brain death, it is irreversible loss of all brainstem functions. Then we call that as a brain death. Locked in syndrome, person is arousable and aware, but there is no motor function except vertical eye movement. There is one stage in a psychiatric disorder we call it akinetic mute, where person can be aroused, is aware, but there is no motivation. So that's why there is a word utilized. Means absence, kinetic means movements, and person is mute. He does not speak, he does not want to communicate. He is aroused, it is arousal, awareness is there, but person do not have any motivation, and this is very commonly because of damage to frontal lobe. So we have already described a vegetative state. This is vegetative, means there is a damage to the brain, but brainstem and spinal cord are intact. While locked in syndrome, brainstem is damaged, cerebral cortex and brain is normal. That's why this is word used. This is locked. So person is aware, awake, etc. but unable to move and speak. While here he is awake but unresponsive stage. So we sometimes use the word awake coma. So person will have a eyelid opens, yawning, swallowing, limbs movement, head movement will be there. But he is not responsive. He is unresponsive. Akinetic mute I have already described. There is one more stage in a psychosis we call as a catatonia, where there is no voluntary movement, no responsive movement, eyelid elevation is there, blinking is there, but person has got no brain damage, and that is described as catatonia. It is sometimes described as catatonic schizophrenia. And if you are interested at your leisure time, whatever we have discussed at present regarding brain death, coma, vegetative stage, akinetic mute, delirium, locked in syndrome, what are the difference in arousal, awareness, sleep-wake cycle, motor function, respiratory function, EEG, and cerebral metabolism, etc. So just go through your at leisure time. Now let us go through etiology. We can divide into two big groups, intracranial and extracranial, means inside the skull and outside the skull. Inside the skull, above the tentorium, we call supratentorial. Below the tentorium, we call transtentorial and infratentorial. There can be infection, trauma, vascular tumor, hydrocephalus, etc. Now this is little important because if there is any pathophysiology which is supratentorial, usually brainstem is spared, while if it is infratentorial, brainstem is affected very early, and this will have a lot of brainstem function being affected, cerebellum being affected. So if a person comes to you with a altered level of consciousness with a brainstem reflexes being affected and cerebellum being affected, it is more of infratentorial lesion, and if that is cerebellum is being spared, brainstem reflexes are little bit preserved, it is more chance of supratentorial lesion. It can be infection, trauma, vascular tumor, hydrocephalus. And among extracranial groups, there are a lot of conditions like metabolic disorders, diabetic ketoacidosis, hypoglycemia, lactic acid acidosis, hyperosmolar coma, drugs toxicity, alcohol, hypoxia. One, don't forget hysterical, or we call pseudocoma, electrolytes like hyponatremia, calcium imbalance like hyper and hypo, magnesium, hypermagnesemia, cerebral edema which can be because of many causes like hypoxia, toxic damage, hypertensive encephalopathy, etc. You can have dehydration, poisoning, toxic damage, hyperpyrexia, hypothermia, also in case of hypothermia also. Still, there may be many causes which I am missing. Say like even endocrine disorders also can have effects. So we divide into two big groups, intracranial and extracranial. Now out of this, if you look at the causes which has got the highest mortality, metabolic groups, head trauma, anoxia, stroke. You can see anoxia is almost 90% and see the stroke almost 80% approximately mortality. And again among stroke, intracranial hemorrhage. So if you look, this is intracranial, traumatic injury and stroke, intracranial, while metabolic disorders, anoxia is extracranial. So these four condition accounts for the majority of the group, and then comes one which is partly intracranial called status epilepticus, but this status epilepticus can be precipitated by extracranial groups like metabolic disorders, hypoxia, hypothermia, etc. can precipitate status epilepticus. And in an extracranial group, another is a drug overdose. This is accounting for only 5 to 10%. but these are the major groups. So always search for these groups because metabolic hypoxia are reversible condition. Reversible condition. So always search for reversible condition and dangerous condition. And if you treat them early, person gets a full recovery. So try to. Even in status epilepticus, results are good. Prognosis is good. If detected early, treated early. While in a case of a severe head trauma, in a massive hemorrhage, the prognosis is always poor. You can see here 80%. In severe hypoxic damage, 90%. In head trauma, 50%. So always try to rule out those causes as early as possible. So etiology we can also divide into structural damage, non-structural causes, or we call intracranial, extracranial. They can be compressive, they can be destructive, or they can be here, they can be metabolic. You can divide into supratentorial, infratentorial, and transtentorial. These are called intracranial, these are called extracranial. And in extracranial, it can be many more. In intracranial, we have already divided infection, trauma, tumor, vascular, raised intracranial pressure, miscellaneous group like hydrocephalus, epilepsy, post-ictal phase, or also we can use the word in case of eclampsia. Among infection, bacterial, viral, tubercular, cerebral malaria, or P. falciparum. Traumatic we call concussion, contusion, laceration. Contusion and laceration will produce prolonged coma, while concussion will be temporary loss of consciousness. Among tumor, benign, malignant, or secondary metastasis. Vascular, most common is subarachnoid hemorrhage, intracranial hemorrhage. In case of occlusive disorders like thrombosis, embolism, if there is a massive damage to cerebral cortex, then you can have an altered level of consciousness, or if there is a basilar artery damage, which damages the brainstem, you can have an altered level of consciousness. Any condition which results into raised intracranial pressure can also produce altered level of consciousness, and because of what we call as a herniation, also you can have an altered level of consciousness. Hydrocephalus very frequently because of raised intracranial pressure and herniation can produce altered level of consciousness, while in seizure particularly there is a stage called as stage of coma or ictal stage or post-ictal stage. In that stage, person will be unconscious. During epilepsy and post-ictal stage, person will be unconscious. So this is roughly what is being divided. We have not included immune mediated and we have not included hereditary groups. So we have told you infection, trauma, vascular, toxic or metabolic, this is extracranial group, this is malignant groups. So these are some of the, and broad term which is being utilized, we use is encephalopathy. So these are some of the odd conditions which can be there in a vascular group. We call the PRES, we call posterior reversible encephalopathy syndromes. So that is called PRES. You can have anoxic ischemic damage and you can have a diffuse axonal injury. Rarely you can come across fat embolism. Among infection, we already mentioned meningitis, encephalitis, brain abscess, tubercular meningitis, etc. There is one more condition called as acute demyelinating encephalomyelitis, or short form called ADEM. Or you can have neoplasm producing encephalitis called neoplastic, paraneoplastic encephalitis, because it is inflammatory pathophysiology. Among toxic, carbon monoxide poisoning, osmotic demyelination syndrome, hepatic coma, uremic coma or hepatic encephalopathy, uremic encephalopathy, thyroid encephalopathy, adrenal disorders, panhypopituitarisms, drugs like serotonin syndromes, etc. And there are some hereditary disorders where you get lactic acid acidosis and it mimics like strokes. There is one called as a prion disorders. And in neoplastic, very commonly because of SOL, raised intracranial pressure, and herniations, or maybe because of carcinomatous meningitis, etc. Usually we divide into disease with focal neurological signs, means intracranial groups. We have already mentioned these intracranial groups. The word commonly utilized, altered level of consciousness with focal neurological signs. And if there is a meningeal signs associated with focal signs and altered level of consciousness, very commonly seen in case of subarachnoid hemorrhage, acute bacterial meningitis, viral encephalitis, carcinomatous meningitis, parasitic pituitary apoplexy, etc. This will be one group you should keep it in mind, where it can be focal with meningeal signs. And when there is no focal signs or there is no meningism, there are big list: hypoglycemia, diabetic ketoacidosis, hyperosmolar non-ketotic coma, lactic acid acidosis, uremic encephalopathy, hepatic encephalopathy, hypothermia, hyperpyrexia, hypothermia, hypoxia, carbon dioxide narcosis, carbon monoxide poisoning, electrolyte imbalance like hyper and hyponatremia, magnesium, excess of magnesium, calcium, excess of calcium, dehydration, cerebral edema, acidosis most common, toxin like urea and ammonia, we call uremic, and we call hepatic encephalopathy. Myxedema can produce coma. Addison's disease can also end up with a coma stage, or we call acute Addison's crisis because of severe hypotension. Sedatives, narcotics, alcohol, opium poisoning, organophosphorus poisoning, opium poisoning, etc. can also produce altered level of consciousness. Hysterical, akinetic, mute, catatonia, these are all we call psychiatric disorders, where also you can have altered level of consciousness. Eclampsia can also produce. This will be basically extracranial group. Deficiency like thiamine, niacin, pyridoxine can also produce altered level of consciousness. Ischemic strokes, ischemia because of shock stage will produce hypotension and hypoxia. Or you can have hypertensive encephalopathy also producing cerebral edema, but the etiology is extracranial groups. Still many more may be remaining here. So these are called without focal signs and without meningism. All those we have already mentioned. There is one another group we call as a temporary loss of consciousness. Temporary loss of consciousness, where you can divide into two big groups. Because of head trauma, particularly we use the word concussion. In case of a contusion and laceration, it is not temporary, it is for long time. Prolonged alteration in level of consciousness. In a non-traumatic group, which can be temporary, which lasts for few minutes to hours. In syncope, and in syncope, it can be vasovagal, orthostatic hypotension, cardiac groups like cardiac arrhythmias, and structural heart disease like HOCM, hypertrophic obstructive cardiomyopathy, or tight aortic stenosis. Seizures, particularly generalized tonic-clonic seizures, atonic variety, we call generalized variety. Psychiatric groups and rare conditions, which also you should keep it in mind, like subclavian steal syndromes, TIA, particularly vertebrobasilar TIA, good number of cases of subarachnoid hemorrhage, also in case of cyanotic spell in children. These are all conditions which can have a temporary loss of consciousness. You should keep it in mind. So if a person said he was unconscious for few seconds to minutes, suspect syncope, epileptic seizures, psychiatric conditions, hysterical individuals, and this rare groups like subclavian steal, TIA, particularly vertebrobasilar TIA, subarachnoid hemorrhage, and cyanotic spell. Do keep it in mind. This is very, very important. These are all those syncope we already mentioned, neurally mediated like vasovagal, sensitive carotid sinus, situational syncopes, orthostatic like drug-induced autonomic failure, maybe primary, maybe secondary, and in secondary very commonly is diabetic autonomic neuropathy. Cardiac arrhythmias like brady or tachyarrhythmias, long QT, short QT syndromes, Brugada syndromes, ARVD, benign early repolarization syndromes, structural disorder we already mentioned, aortic stenosis, hypertrophic obstructive cardiomyopathy, pulmonary hypertension, and we call miscellaneous group like psychogenic, metabolic disorders, and we already told you subclavian scale syndromes. Also in case of vertebrobasilar TIA and cyanotic spells. Do keep it in mind. Now how you approach to a person. Now we come to the main part. Or a person is, we sometimes mention altered mental status or altered level of consciousness. First is always from a history or from a general examination. Easily you can make out the person is having head injury or not. So always divide into two big groups. Traumatic groups, non-traumatic groups. So first I am talking regarding a traumatic group. So person is having altered level of consciousness. I'll use a broad term like coma. So maybe right from drowsy to comatose stage. We call altered level of consciousness. So person is having altered level of consciousness or a person is comatose. There is external injury on the head, maybe a severe brain injury, maybe an open scar, open wound, or maybe a closed wound. And person is having CSF otorrhea, CSF rhinorrhea, meaning or bleeding from ENT we call, or CSF otorrhea or rhinorrhea, meaning there is a fracture basal skull. And if this particular person is having no pulse, no heart sounds, no respiration, don't wait for investigation, because this is almost we call as a close to brain death. Immediately shift to a center where person can be treated. This can be severe traumatic brain injury because of head injury, or person is in a brain death. So as early as possible you shift him to a center where he can be treated. So this is one group. Second group, person is in a comatose stage, he has got a head injury, he has got CSF otorrhea, rhinorrhea, but there is pulse, there is some respiration, there are heart sounds. So in a vital data you are getting pulse, blood pressure, heart sounds, respiration. So he has got a traumatic brain injury. Now in this particular person you can examine properly and go for treatment. I am not discussing regarding that particular part, but the first thing what you have to do is stabilize the cervical spine. So stability to the cervical spine should be done first and then shifted to the center. Now there is a one second big group we call non-traumatic groups. Now in a non-traumatic group I divide into many subgroups. If there is no history of trauma but person is unconscious, there is no pulse, no respiration, no heart sounds, immediately suspect cardiac arrest. I am not discussing here in detail regarding cardiac arrest because we have already discussed that particular. You can go through in my website, or sorry, in my YouTubes. I have discussed sudden cardiac death. I have discussed also cardiac arrest, that in detail. So if you suspect a person is in a cardiac arrest, immediately what you should do is CPR, ACLS, advanced cardiac life support, and try to find out whether it is VTVF, we call pulseless electrical activity, or person is in a cardiac arrest, and depending upon that you decide what to do. I am skipping this particular part. Say person is having non-traumatic and pulse is normal, blood pressure is normal, respiration is normal, heart sounds are normal, no neurological findings, etc. Always try to rule out pseudo coma, or we call it a psychogenic. So this should be differentiated from true coma. we'll be discussing, we'll be showing you 1 or 2 slides how you differentiate psychogenic from true coma. Say there is another group where person is having coma or altered level of consciousness, pulse is there, respiration is there. Now you have to decide by CNS examination, means by a good examination, whether it is intracranial or extracranial. For that, we'll do how you approach to that particular group of people. So any person, so just I'm repeating again, if there is a traumatic injury, first look at the pulse, respiration and heart sounds. If they are absent, stabilize the cervical spine and shift him immediately. If they are present, again stabilize the cervical spine and shift them. Particularly if the person has got a head injury with CSF otorrhea, rhinorrhea, or if there is a bleeding from ENT, ear, nose and throat we call. Bleeding from ear, bleeding from nose or bleeding from oral cavity. These are bad signs. So transfer them to a trauma center so they can be managed well there. And if a person is having no trauma, no history of trauma and there is no signs of external injury and there is no pulse, no respiration, no heart sounds, do suspect cardiac arrest. And immediately you can start CPR, use ACLS and try to find out what arrhythmia it is. If these are absent, person is having no traumatic injury, non-traumatic, but person is having pulse, respiration, heart sounds, blood pressure, everything is normal, CNS examination is normal, do look out for pseudocoma or we call psychogenic. And now suppose if the person is having some neurological symptoms and signs, maybe a bilateral signs or maybe localizing sign or maybe a meningeal sign, suspect intracranial or extracranial. So if there is a coma with focal signs, suspect intracranial. If there is a coma with focal signs, with meningeal signs, again in intracranial, subarachnoid hemorrhage, intracranial hemorrhage and we call itis, that is meningitis, encephalitis or tubercular meningitis, fungal meningitis, etc. If there is a coma, there is no focal signs, no meningeal signs, extracranial groups. If there is a coma, always, if there is no focal sign, no meningeal signs, first try to find out reversible causes like hypoxia, electrolyte imbalance, metabolic groups, hypoglycemia, etc. Hypoglycemia, decay, hyperosmolar coma, lactic acid acidosis, all those groups which are reversible. Now say if there is a temporary loss of consciousness and by and large good number of time it is reversible. So look for syncope, epilepsy and psychogenic group. Now there is another group where there is a slowly deterioration in level of consciousness. And if there is a slow deterioration in level of consciousness, always suspect raised intracranial pressure, tubercular meningitis, hydrocephalus, tumor, subdural hematoma, etc. So always look for those groups, SOL, those groups. Intracranial pressure elevated, subdural hematomas, extradural hematoma, SOL like brain abscess, metastasis, tumors, benign, malignant tumors, hydrocephalus, tubercular meningitis, all those groups. Now this is one slide. What we have mentioned before is put in a what we call as a diagnostic approach group. So initial assessment done by vital signs. First, initially always look for circulation. Circulation is now said to be first. airway and breathing. If there is a no gag reflex and if the Glasgow coma scale is less than 8, immediately intubate. That is to be done. Oxygen, monitor, bedside glucose, and you can give even what we call as naloxone for opium poisoning if there is a suspicion clinically and on examination if there is a pinpoint pupil and person was found to be addicted. And if there is a history which is suggestive of a traumatic injury, and if there is no traumatic injury, this will be the algorithm. And if there is a traumatic injury, first cervical spine immobilization. Look for the signs of herniation, that is Cushing response. Blood pressure is elevated and there is a bradycardia. And there is a unilateral dilated pupil. It shows the signs of herniation. So this will be the early signs what will tell you that there is a raised intracranial pressure and herniation is started. Particularly what we call is an uncal herniation, in which you will have a unilateral pupil dilatation and you will have a blood pressure elevated and bradycardia in opposite directions. For that person, you elevate the head, put the head in the center. Neurosurgical consultation should be done. If respiratory rate is high, you can give oxygen, mannitol, and then surgical intervention like craniotomy, ventriculostomy, etc. And you can confirm that a SOL or a hematoma or hemorrhage by CT or by MRI. Nowadays, you can utilize even what we call as echoencephalography. So CT can be done, you can pick up lesions, you can have a neurosurgical consultation, and if there is nothing on a CT, then you can suspect toxic metabolic disorders and then try to find out that toxic or metabolic conditions. If there is no such things, you can go for a lumbar puncture to rule out inflammatory pathophysiology. Now, if there is no traumatic injury, before starting an antibiotic, always go for a lumbar puncture. But you can take the advantage of CT scan, and if there is nothing on a CT scan, you can go for a lumbar puncture. If infection is suspected, antibiotics. If infection is not suspected from a CSF examination, rule out toxic condition and metabolic conditions. If there is no suspicion of infection, means person was not having high temperature and there was no past history of fever, headache, nausea, vomiting, no meningeal signs, then have a ECG, CT scan, have a laboratory parameters for metabolic disorders, toxic conditions, toxicology, and go accordingly. So that is how usually the person is proceeding. So look for focal signs, you suspect these groups. Focal signs, suspect intracranial pathophysiology. There is no focal signs, suspect metabolic disorders, toxic conditions, extracranial groups. If there is a meningeal signs, infective pathophysiology groups. And bleeding, subarachnoid hemorrhage, intracranial hemorrhage. If there is a temporary loss of consciousness, we already mentioned syncope, epilepsy, psychiatric groups, subclavian sleep syndromes, vertebrobasilar artery TIA, etc. And if everything is normal, suspect hysterical. And in an hysterical person, we don't require all these investigations. You can diagnose clinically. And if at the initial stage only, if the pulse is absent, respiration is absent, heart sounds are not heard, do suspect cardiac arrest and treat fast. First CPR, in CPR, circulation, airway, breathing, and chest compression. And then depending upon the rhythm, you can decide regarding defibrillation. Intubation should be done if there is a no gag reflex and Glasgow coma scale is going towards severe variety. So in that case, intubation should be done. Now first part, very important slide. Good number of time you will come across this particular, we call psychogenic coma or pseudocoma. Now this is very peculiar, very common in female. Patient will hold the eye tight when you try to open. He will resist, she will resist, sorry, opening of the eye. Or sometime fixed stare look, there will be blinking. If you examine the pupil, normal pupillary reflex, or we call normal light reflex. There will be normal oculocephalic or brainstem reflexes. Caloric test will show you nystagmus. There will be normal posture, normal breathing, normal blood pressure, pulse. So vital data will be normal. CNS, elementary, respiratory, cardiovascular system examination will be absolutely normal. And episodes will be recurrent and mainly in presence of the relatives. Good number of time person will be hyperventilating. There will be abnormal posture of the arms, legs, head, neck, etc. Now person, if he is in a deep sleep, during that deep sleep also person will have a blinking, movement of the eyeball, movement of the arms, body, etc. And person will respond to deep painful stimulus or even to a strong smell like onion, garlic, ammonia, spirit, ether, etc. This condition is good number of time misdiagnosed as seizures and also misdiagnosed as CNS lesion. CT scan, MRI scan, lot of investigation, big bunch of investigation are being done and even treated and admitted in an ICU. So also malingering depression cases can present as a pseudocoma or we call a hysterical coma. We have already told you lids will be closed, person will resist opening, stare look, blinking, pupils will be normal response. What we call is a brainstem reflexes will be preserved, motor tone will be normal, but person will resist your what we call as a passive movements. Hyperventilation will be very common. Reflexes, person will not allow you to take a reflexes. EEG will be absolutely normal and all system examination, cardiovascular, elementary, respiratory, CNS, everything will be normal. Vital data will be normal. Now suppose we take that person is not having pseudocoma, person is having altered level of consciousness, immediately look for respiration, pupil, what we call as a brainstem reflexes and motor response. Fast. If respiration is absent, pupil is dilated, pulse is absent, no heart sounds, immediately starts chest compression to maintain circulation, airway and breathing. We usually now use the word CAP. We don't use the word ABC. And if ECG facilities is available, look for ECG rhythm. If it is showing VT/VF, go for defect. If it is pulseless electrical activity or there is a cardiac arrest, don't do defect. Don't do defibrillation. So this is a prime thing, what to be done. And this should be done at the site, wherever you find the person to be unconscious. And this should be done for at least minimum 10 to 30 minutes. And even if after that, if the pulse, blood pressure, respiration does not come, it is a dangerous sign. And while doing this, call for emergency and send him to an ICU where advanced cardiac life support is available. This is what we call as a basic life support. So there is something called as a DRAP CD, danger, response, airway, breathing, compression and defibrillation. I've discussed in detail in a chapter of what we call as a cardiac arrest. Also I have a video lecture in my YouTube on ACLS. So always there is a term, no management of coma at home. But if you find a person comatose and in a cardiac arrest, don't wait for a shift. Start chest compression. Circulation, airway and breathing should be started. It should be a priority, first priority. Give oxygen. Try to maintain as much airway, breathing and circulation as possible, and then call for the emergency ambulance, call for the help and shift to an ICU. We have already told you some of the things we have discussed before. Always look for respiration pulse in cardiac arrest and respiratory arrest. First thing is BLS, that is chest compression, circulation, airway and breathing, followed by defibrillation if a person is having shockable rhythm, and then you should be shifted to an ICU for advanced cardiac life support. So after finishing this, a history, physical examination, vital data, CVS examination, CNS, alimentary system, respiratory, everything. Differentiate between true and pseudo. If it is pseudo, you don't require any additional treatment. You require only psychotherapy. If it is true, now try to find out whether it is traumatic, non-traumatic. We have told you on the first stage. If it is non-traumatic, rule out intracranial or extracranial, because traumatic, if there is an injury to the brain, then only the person will be having altered level of consciousness. If there is a traumatic injury below the spine, less likely to be person in a altered level of consciousness unless there is a very bad chest injury or person has gone into severe coma stage, or a shock stage, and person has developed severe hypotension, shock and hypoxic conditions like tension pneumothorax, traumatic tension pneumothorax or flail chest. If you can identify what is the intracranial and extracranial, treat the basic cause. If you can't identify, always rule out hypoglycemia, give IV glucose. For wernicke encephalopathy, thiamine. For we call narcotic overdose or narcotic toxicity like opium poisoning, naloxone. And for benzodiazepine overdose, flumazenil. In any person who is unconscious and gag reflex is absent and person is vomiting, Ryle's tube is a must. You can have IV fluids, you can have a TPN, total parenteral nutrition. And through all these three, whatever is possible, water replacement, so water balance, nutrition, electrolyte balance and minerals should be given. Take care of eye, skin, bladder, bowel and oral care. Change the position frequently, use water beds or air beds to prevent bad sores. Prevention of DVT, prevention of aspiration, prevention of pneumonia and prevention of bad sores should be done. This is in general. So all those things what we have mentioned, breathing, management of shock, glucose, intoxicating drugs, electrolyte, do the laboratory test for all this. Intracranial pressure, if it is elevated, treatment for that. Lumbar puncture should be done in a suspected case of infection, subarachnoid hemorrhage, intracranial hemorrhage. If the person is having convulsions, that should be controlled because that can worsen and person can go into status epilepticus. If person is having vomiting and gag reflex is absent or we call brainstem reflexes are absent and there is a chance of gastric aspiration, put a Ryle's tube and have a gastric aspiration. If person is having hyperpyrexia or hypothermia, fever control, bladder and bowel should be taken care. Management of electrolyte and potassium imbalance, avoid aspiration pneumonias, DVT prophylaxis, All these things should be done. Eye care, skin care, bladder and bowel care. So we divide into two groups, emergency care and long-term care. In emergency, we have already described, we call CAP, that is, previously it was ABCD. Now instead of ABCD, we call first circulation followed by airway and breathing. And then you can go for defibrillation, depending upon. Start oxygen, fluid therapy, laboratory test, meanwhile, another person can collect. We have already mentioned regarding this glucose, ABG, electrolyte, magnesium, calcium for toxicology study, ammonia, urea, etc. should be done. This is for ruling out extracranial groups, and reversible causes should be treated. We have already mentioned glucose, naloxone and flumazenil. This is for benzodiazepine overdose. So after ruling out pseudocoma, locked-in syndrome, or we call vegetative stage, where you don't require any one of this, and in case of suspected focal signs and infection, lumbar puncture and CT scan. If there is meningeal signs, then go for lumbar puncture and CT scan. In a focal signs, again CT angio, MRI angio. You can go for even echoencephalography, etc. and try to find out. There are a lot of different types of neuroradiology which can give you an answer. This we have already mentioned. At your leisure time, you can go through. Thiamine is in Wernicke's encephalopathy. This is for hypoglycemia. Naloxone is for opium poisoning, or we call as a opium overdoses. Stop seizures. Treat metabolic disturbances. If there is an intracranial pressure elevated, try to lower that. And if there is a suspected infection, treat infections. So go through your at leisure time. This is one flow chart. So it is usually said that even this can have altered level of consciousness. So have a good history, good examination, look for comorbid conditions, look for history of medication, toxic substances, etc. and history regarding previous episodes. If person is unstable, start IV fluids, cardiac monitor, oxygen, laboratory parameter, and if a person is having traumatic injury, stabilize the cervical spine. And if person is unstable, particularly if person is hypoxic, gag reflex are absent, then intubation and hemodynamic support should be given simultaneously. If person is having no localizing sign, then look for sodium, calcium, sepsis, Wernicke's encephalopathy, poisoning, toxicology studies, etc. We have already mentioned regarding that. In a case of poisoning, activated charcoal can be utilized. Gastric aspiration, we already mentioned thiamine, flumazenil, then naloxone, etc. All that should be utilized. If there is a seizure, I've got a next slide. You can use lorazepam, diazepam, phenytoin sodium, phenobarbital, or sodium valproate. This already we have mentioned. In ethyl alcohol, you can give thiamine and you can use sedatives. And in presence of seizures, for ethyl alcohol seizures, you can use thiamine, dextrose, lorazepam. Try to correct electrolyte imbalance, and if there is another metabolic disorders, treat accordingly. Go through these slides at your leisure time. It is a very long topic. If I try to cover up everything, it will take many hours. So I'm trying to skip some of those things. At your leisure time, you can go through easily. This is if any person who comes in a status epilepticus, then you can go for this. First, oxygen, continuous monitoring, laboratory parameters. Lorazepam is the most common drug which is being preferred in a first line. If you don't get the results with lorazepam, you can go for phenytoin sodium or sodium valproate or levetiracetam. Intubate the patient, and if still you do not get a result, go for general anesthesia, and in that general anesthesia, short anesthesia by midazolam or propofol. These are the two common being utilized, and look for EEG if possible. And if EEG is still showing you abnormal electrical activity, treat as a malignant status, and you can induce what we call the phenobarbital comatose conditions. Phenobarbital induction should be done, and then slowly you reduce that thing. This is usually said at 0 minute. This is between 5 to 10 minutes. Does not recover within 10 minutes, go for second line. Does not recover in 20 minutes, go for general anesthesia. Does not recover in 30 minutes, go for phenobarbital induction. If a person comes with a raised intracranial pressure, first is position elevated to 30-degree angle, midline head positions. By and large, if facilities is available, you can go for ventriculostomy or craniotomy, surgical intervention. But first, before even doing this, mannitol and hypertonic saline is the most commonly being utilized. We call osmotherapy. Glucocorticoids is very useful in presence of vasogenic edema because of tumor or abscess, or also in case of a head injury. Hyperventilation will be very useful to wash out and bring the CO2 between 30 to 35. If a person has got severe hypotension and shock, dopamine or norepinephrine drip is utilized. We call vasopressor drugs. And if a person is still not recovering, you can go for craniotomy. And we have told you one more thing, that you can induce phenobarb coma to reduce the metabolism of brain by inducing phenobarbital coma. But it is also one of the therapy which is utilized in a person with status epilepticus. You can induce hypothermia. So you can go for hyperventilation and bring the CO2 back to 30. You can utilize mannitol or hypertonic saline. So raise the head to 30-degree mid position, hyperventilation, sedation, osmotherapy by mannitol or hypertonic saline, then surgical intervention, induction of hypothermia, treatment of hyperthermia and hyperpyrexia, phenobarbital coma, all are the procedures which are commonly being utilized. So these are all the things. You can also use ventriculostomy for monitoring and for even removal of CSF. This is ventricular drainage. So you can put a needle. This is craniotomy. This is ventricular drainage. You remove a small amount of CSF fluid so that you bring down the intracranial pressure close to normal. So craniotomy, shunting, all these are all the different pictures you can go through. This is decompression surgery which is being done. Now say a person recovers from what we call as a non-traumatic conditions. But while investigating, before even investigation, what is most important is a good history. First is maintain the vital data. Stabilize the cervical spine in case of traumatic injury. And in person with an intracranial or extracranial, maintain the vital data and get a good history from relatives, paramedical persons, ambulance persons, bystander, what was accompanying, etc. Wherever it is possible, old file, old reports, old history, history of drugs, past disease, etc. And examine the person, find out the severity of the coma, and try to come to the closest differential diagnosis. For that, you take a good history of onset, fever, history regarding fever, headache, vomiting, trauma, change in recent behavior, history of diabetes, hypertension, control, uncontrolled, regularity regarding medicines, regularity regarding food, etc. Look for poisoning and other history also. Among drugs, oral hypoglycemic, insulin, antipsychotic drugs, sedatives, steroids, anticoagulants, diuretic because this can produce electrolyte imbalance, water imbalance, alcohol intake, acute or chronic, seizure disorders, prior episode of coma, transient loss of consciousness prior, etc. Try to get all those history. So history from relative, friends, associates, vital data examination and journal examinations, level of consciousness by using different parameters like Glasgow Coma Scale, AVPU, ACDU, 4 score, revised trauma score, etc. Then higher function you cannot examine speech, IQ, memory, sensory localization, you cannot examine. For that you require the person to be alert and aware. In CNS or we call in CNS examination, after examining level of consciousness, speech, etc. you should, this is not possible. Cranial nerve examination, look for pupillary reflex, corneal reflex, gag reflex, doll's eye movement, caloric test. These are the only possible in cranial nerve examination. Other parts of cranial nerves you cannot examine. Sensory system also very difficult, you can't examine sensory system. In motor system, we usually examine by Glasgow Coma Scale or AVPU, like response to verbal stimulus or we call external stimulus, passive movement on painful movement, response in motor movements. Reflexes, superficial reflex, difficult. Deep tendon reflex also good number of time it is difficult to elicit, or we also mentioned sometime absent or difficult to elicit. And plantar reflex is also difficult to elicit, but usually in a coma it is bilateral extensor. But if it is unilateral extensor, it is focal signs or we call localizing sign. If on one side the reflexes are present and on another side the reflexes are absent, again it is a focal signs. So try to look in a motor system and reflexes to find out a localizing sign. It is very, very important, and also cranial nerve examination tells you the localizing signs, because any localizing sign is intracranial. And along with that, look for meningeal signs like neck rigidity, Kernick sign, Brugschinski sign. If there is a neck rigidity, suspect intracranial hemorrhage, subarachnoid hemorrhage, meningitis, encephalitis, tubercular meningitis, fungal meningitis, etc. Also, sometime in a person with a raised intracranial pressure also, you can have a neck stiffness. Look for signs of raised intracranial pressure in the form of person will have a persistent vomiting, papilledema. Because if the person is deeply comatose, he'll not complain of headache. Person might have convulsions also. And also look for what we call as a Cushing signs. In that Cushing signs, the person will have a hypertension, bradycardia, abnormal respiration, abnormal pupil. So look for that. Also look for herniation signs. Cardiovascular, respiratory and alimentary systems should be examined properly. Now there are few tips which can be there. If the person is having swallowing reflex, the person is having crossed legs, yawning, swallowing, cough, etc. Person is awake, by and large person is in a drowsy stage, or we call it the light coma or drowsy, or person may be in a delirious stage. If person is having lack of restless movement on one side, means focal signs, and outturn leg at rest, one leg is outturned, is externally rotated, means focal signs. So very commonly in a hemiplegia, we call focal signs. Or person is having multifocal myoclonus. It is very frequently in a metabolic disorders. Person is drowsy, confused, and there is bilateral ataraxis, abnormal movements. It is more in favor of metabolic encephalopathy. Particularly say hepatic coma, uremic coma, carbon dioxide narcosis, those group, hypoxic conditions. If there is jaw and lid tone, the person has got open lid or there is a hanging jaw, more in favor of a severe coma. So always have a full examination at vital data like heart rate, blood pressure, respiration, temperature. Very, very important. Some of the points we'll be discussing. Look at the pupillary sign. This is we call as a vital data signs. And then look at the brainstem. That is vestibulo-ocular reflexes like caloric test, doll's eye movement, corneal reflex, cuff reflex, gag reflex. Look at pupillary reflex, pupil size at rest, and then look at the motor response. This is a fast, rapid examination what you can do. And also look at the type of respiration, which is very, very important. If there is a very slow respiration, very commonly in opium and barbiturate poisoning and in myxedema coma. Tachypnea with hyperapnea in diabetic ketoacidosis called Kussmaul's breathing. Also you can get in uremia, pulmonary edema, raised intracranial pressure. Also sometime in case of pneumonia. Chain stroke breathing in severe raised intracranial pressure. Bayard's breathing also in case of a severe raised intracranial pressure, almost when the brainstem centers are getting damaged. If there is a severe bradycardia, cardiovascular causes, maybe because of drugs also. Also in myxedema coma, and also as a Cushing sign in raised intracranial pressure. If person is having severe hypertension, intracranial bleed, raised intracranial pressure, hypertensive encephalopathy. If there is a severe hypotension and shock stage, diabetic ketoacidosis, alcohol intoxication, barbiturate poisoning, intracranial hemorrhage, acute MI, dissecting aneurysm, septic shock, Addison's crisis, massive traumatic brain injury, etc. This is a possibility. This is what we have called Cushing triads or Cushing sign or Koch's Cushing response. Elevated blood pressure and bradycardia due to increased intracranial pressure. And when there is a compression of the floor of the fourth ventricle, there is also tachypnea, increase in respiratory rate. And late stage, there is a fall in blood pressure and associated with tachycardia in a terminal stage. There will be hypotension with tachycardia. This is classical Cushing triad, what you come across. While looking at the Glasgow Coma Scale, we look at the eye response, verbal response, and motor response. We call EVM. In an eye, if eye opens spontaneously, 4 score. Eye opens on a verbal response, we give 3 points. Eye response, opening response only to pain, 2 points. And eye response, even to pain, there is no response. Eye is not opening, 1 point. As far as verbal response is concerned, person is fully oriented, 5 points. Person is confused, 4 points. Person is having what we call as a irrelevant behavior, inappropriate word, 3 points. Person cannot produce a sound, or person cannot communicate, or person becomes totally disoriented, 2 points. And there is no response to verbal stimulus and speech is totally absent, we call 1. Person has got a spontaneous movements or on oral commands or on order. He obeys all oral commands, 6 points. You give a painful stimulus. Person localizes the pain and tries to withdraw your arm, 5 points. Person will try to withdraw from pain by withdrawing arms or movement of the part of the body, 4 points. And if on painful stimulus there is a flexion of the upper limb, 3 points. If there is an extension, we call this is decorticate. Extension, decerebrate posture, 2 points. And if there is no motor response, 1 point, or we call flaccid. So when all the points are put together, if person is having 15 points, normal or we call conscious, less than 15 but more than 12, then we call as a mild. And if it is between 12 to 8, we call moderate. And if less than 8, we call severe. This is coma, this is stupor, and this is called drowsy. Very easy. This first group, 15 points, normal or we call conscious. This, drowsy, stupor, and below this means right from 3 points to 8 points, up to 8 points. We call that as coma. I'm skipping over this particular. So mild, moderate, and severe. Between 3 to 8, severe. Between 9 to 12, moderate. Between 13 to 15, minor, or we call drowsy. Less than 15, drowsy. This Glasgow Coma scale is utilized for baseline, to find out the severity of damage, and for progress while you are giving a treatment. If there is no improvement and person is deteriorating, your treatment is not proper. If person is improving, proceed. If person is again deteriorating, re-evaluate. So that can be utilized. And whenever you mention, you have to mention Glasgow Coma scale is 9. You can separate out E, V, M, put the separate groups, and at what time. That should be written. So that helps you for prognosis and the progress of the person. So 15 normal, more than 11, 5 to 10% chance of vegetative stage. Between 3 to 4, 85% of the chance of vegetative stage. If person remains in a same Glasgow Coma scale for a longer period, person will go into vegetative stage. There are other modes we call as a 4 score, that is full outline of unresponsiveness, where you are utilizing eye response, motor response, brainstem reflexes, and respiration. This is another way which is being utilized. Very frequently, this is also one of the best way of utilizing, where you are utilizing a brainstem reflexes and respiration, which is not utilized in what we call as Glasgow Coma scale. That should be added in this. AVPU is the most simple, most and a very fast way of just putting them into what group, that is alertness, verbal response, painful response, and unresponsiveness. While in ACDU it is alert, confusion, drowsy, and unresponsiveness. In a Grady scale, it is you are utilizing 1 to 5, that is different stages, that is right from confusion, stupor, deep stupor, and coma, etc. So this is AVPU. If person is fully alert, we call A. Person responds to verbal stimulus, that is drowsy, that is we call V. And person responds to painful stimulus, we call stupor. And person is unresponsive, we call as a coma. And as far as ACDU is concerned, same, this is alert. Instead of drowsy, they are using the word confusion. And then they are using the word drowsy. And then unresponsiveness. Stupor word is not utilized here. So in a ACDU, stupor word, confusion and drowsy words are utilized. This is grade coma scale. Grade 1, drowsy and confusion. Grade 2, stupor. Grade 3, deep stupor. Grade 4, decorticate and decerebrate posture. And grade 5, no response to any stimulus. And this is in response to painful stimulus and verbal response. These two parameters are only utilized in grade coma scale. Well, in a 4 score, high response, usually it is 0 to 4 in eye, in motor also 0 to 4, in brainstem also 0 to 4, where you are utilizing corneal and pupillary reflex, and in respiration also 0 to 4, totally 16 score. Here everything is put together. We call Glasgow coma scale with vital data, pupil examination and motor movements. All are added together. This will be the best way of assessing and labeling the person severity, progress as well as the basic stage. There is one another in a trauma where you are utilizing three things together: Glasgow coma scale, respiratory score and blood pressure score, and that is utilized in a revised trauma score. So you utilize three: Glasgow coma scale, respiratory rate and systolic blood pressure. That is utilized there. This is all the different types of breathing pattern. Go through your leisure time. These are the all different types of terminology utilized: eupnea, tachypnea, bradypnea, apnea, hyperapnea, giant stroke, Byrd's breathing, Kussmaul breathing, apneustic breathing, and these are the different etiology. These are the different etiology. Just at your leisure time go through. These are those diagrammatic representation. Same thing is shown here. Diagrammatic representation. And this is shown where will be the damage. In a case of a giant stroke breathing, it will be an extensive damage in the respiratory center. This will be central damage in the midbrain and pons region, etc. So try to go through that. Brainstem reflexes include pupillary reflex, ocular reflex, corneal reflex, and respiratory pattern. Also, it also includes what we call as caloric test, doll's eye movements. So these are different types of pupil. I'm not going into detail, but I'll just give you one idea. If both side pupil is pinpoint and reactive, the damage is above. If there is a unilateral, it is very common in an uncal herniation. Unilateral pupil is dilated. We call anisocoria. If both are midway, not dilated, not pinpoint, mid position, it is very frequently damaged in the midbrain portion. If it is a pinpoint, pons, bilaterally pinpoint, not reacting to light, pons. And if there is what we call is an alternate increasing and decreasing, it is a damage in the prefrontal region called hippus, fixed hippus. And if there is a papilledema, it is a bad sign. Severely raised intracranial pressure. This also you can go at leisure, shown you in a diagrammatic pattern. You can go for a doll's eye movement. If doll's eye movement is preserved, we say brainstem reflex is preserved. If calorie text is detectable, again brainstem reflex is preserved. And look for the pupillary. If pupillary reflex are abnormal, there is a damage to the midbrain. So this is papilledema, this is conjunctival test, this is abnormal, we call cranial nerve palsy. This is abnormal pupil, this is one side dilated and one side small size pupil. This is abnormal. So we call anisocoria, again suggest localizing sign, very common in uncal herniation. This is doll's eye movement, how you elicit. And skipping over, this is caloric test which is being done, and observe for the movement of the eyeball. So this is caloric test. When you use the cold water, the eyeball will move towards the site of stimulus, while in a warm water it will move away from the stimulus. This is permutation combination. I am slipping over some of the slide which will tell you the combination of pupillary reflex, brainstem reflexes and motor movement, and which level you got a damage. So these are in detail. Go through your at leisure time. These are all the slides. I'm showing you this one simple. If you give a painful stimulus and if a person gets a flexor response, this is a decorticate, means there is a bilateral extensive damage to the cerebral cortex. And if there is a massive damage to the bilateral hemisphere, then you get a decerebrate posture. And on a painful stimulus, there is a flaccid limbs. Then there is no response. This is a bad sign. So if you give a painful stimulus and person responds and person is able to localize while you are giving a painful stimulus, and person tries to withdraw when you give a painful stimulus, these are the points given in what we call the Glasgow-Coma scale, right from 6 to 1. This is 6, 5, 4, 3, 2 and 1 in a Glasgow-Coma scale. Very hurriedly, to differentiate between intracranial and extracranial, first, if a person has got altered level of consciousness, look for neck rigidity. If there is a neck rigidity present, suspect infection, subarachnoid hemorrhage, intracranial hemorrhage. If there is no neck rigidity, means no meningeal signs. Is there any localizing sign? If there is a localizing sign, intracranial lesions. If there is no localizing sign, metabolic, toxic, etc. So we put into 3 groups: no focal signs, extracranial; focal neurological signs without meningeal signs, and with meningeal signs. With meningeal signs, intracranial hemorrhage, subarachnoid hemorrhage, meningitis, encephalitis, etc. Signs of lateralization, very simple: unequal pupil, abnormal eye position, facial asymmetry, head turned to one side, limb rotated to external rotation, asymmetrical dip tendon reflexes, hypotonia on one side or hypertonia on one side, unilateral extensor, unilateral involuntary movements, we call it a Jacksonian epilepsy or focal epilepsy or focal movements, etc. This is that particular thing what we call as, in a person with a hemiplegia, usually look at the face for asymmetry, look at the arm movements, look at the speech. If the person is in a drowsy stage, then you cannot be able to examine the speech, and T is for times, since how long this is. So face, arm examination, speech examination, and time duration should be done. And this is how you go. This is all herniation symptoms and signs. At your leisure time, you can go through, have a pause and go through that. This is uncal herniation. This is diencephalic stage, upper part, lower part, etc. This is lower pontine stage. In a metabolic encephalopathy, usually person will be in a confusional stage. There will be lot of fluctuation, improvement, deterioration, no focal signs, no neck stiffness, no brainstem reflexes. Brainstem reflexes will be normal. There will be little involuntary movement in the form of a tremors or myoclonus, or we call as flapping tremors, asterexis, etc. will be very frequently seen in a metabolic encephalopathy. This is one thing which will be shown in a person with what we call the different stages of coma in a metabolic variety. I'm skipping over again this. At your leisure time you can go through. That is stage 1, stage 2, stage 3 and stage 4. If there is a neck rigidity in the form of neck stiffness, Kernick sign, Bruggencke sign, this is how you elicit. You try to elevate, you cannot flex at neck rigidity, this is Bruggencke sign. You try to flex at the neck, both lower limb gets flexed, Bruggencke sign. And when you flex at hip and flex at knee and then hyperextend at the knee, you get spasm and person complains of severe pain, that is Kernick sign. On general examination, look for petechial hemorrhages, ecchymosis. Nasal bleed and CSF leak is a sign of a basal fracture skull. This is raccoon eye. That is also a sign of intracranial hemorrhage, or we call head injury. Bleeding from ENT. Try to look for that. Depressed fracture skull, bruising over the mastoid process, we call battle sign. You can see here bluish discoloration. This is called battle sign. We'll have other photographs also. Raccoon eye, this is typical raccoon eye. You can see up on both sides there is a black pigmentation, periorbital region. CSF discharge from ear, nose. You can see a CSF is coming out from ear. And this will be very common in basal fracture skull. Also, you can have tenderness and battle sign on what we call as mastoid process. This is raccoon eye. This is battle sign. This is battle sign. This is raccoon eye. Very classical. You can see very clearly raccoon eye. These are petechial hemorrhages. These are petechial hemorrhages. This is ecchymosis. This person has got edematous and drowsy. Look at the color of the skin. Look for cyanosis. Look for petechia, ecchymosis, skin changes, uremic skin, etc. Cherry red color in case of carbon monoxide poisoning. Plethora in alcoholism. Maculohemorrhagic rash in case of meningococcemia. General examination finding pallor, icterus in hepatic encephalopathy. Even in case of a complication of malaria, we call as black water fever, acute hemolysis. Rash in case of meningococcemia, dengue, measles, rickettsia. Petechial hemorrhages in dengue, meningococcemia, hemorrhagic fever. Hematomas in traumatic injury. Abnormal smell. We'll show you slide on abnormal smell also. You can have a blisters, that is bullous lesion. Abnormal smell in case of alcohol, fruity smell in diabetic ketoacidosis, uremic smell in uremia, fetor, typical musty fetor in hepaticus. It is called fetor hepaticus or hepatic coma. Burnt almal smell in cyanide poisoning, and typical OP smell in organophosphorus poisoning. You can get also needle pricks, tongue bitten in particularly seizures. Have a good history regarding epilepsy, diabetes, drug history. Look at the clothings, handbags for letters in case of poisoning, bottles. Careful examination for trauma and needle marks in drug addicts. Look for temperature, hypothermia, blister, facial puffiness, obesity, nail, clubbing. There are a lot of things. Investigation wise, we divide into two big groups. Intracranial, mainly MRI, lumbar puncture and EEG. While in extracranial, blood count, CBC, random blood sugar, renal function test, liver function test, electrolytes, ABG, urine examination for glucose, acetone, chest X-ray, ECG, etc. Those are very commonly done for extracranial groups. So X-ray skull, epilateral, paranasal sinus, basal view, CT, MRI, CT angio, MRI angio, EEG, fundus examination, lumbar puncture, CSF analysis. This is for intracranial groups. While ECG, X-ray chest, echo for cardiovascular, random blood sugar, liver function test, renal function test, electrolytes, ABG, etc. for extracranial groups. And depending upon the etiology, you can go for T3, T4, that is thyroid function test, glucocorticoid levels, etc. There are many big list. Fundus examination, this is normal, and this shows you papilledema. So I've already mentioned regarding all these different tests. Lumbar puncture examination is very important in ruling out intracranial pathophysiology. So if you come across xanthochromia, more in favor of intracranial hemorrhage, subarachnoid hemorrhage, once in a while in a person with a tubercular meningitis also you can get xanthochromia. But usually xanthochromia will be present after 48 to 72 hours. But if plenty of RBC is present, it is intracranial hemorrhage and subarachnoid hemorrhage. So in those two conditions, you can come across xanthochromia and plenty of RBC. While there are a lot of tests which you can go for calcium, phosphorus, magnesium, thiamine, B12, folic acid, amylase, cortisol level, thyroid antibody, lactate level, etc. These are all for we call as extracranial group or metabolic disorders. Also you can go for toxicology studies. So try to go for that. And in a person with intracranial pathophysiology, we have already mentioned all the big list. This is a difference between bacterial, viral and tubercular. So at your leisure time, go through this particular difference between bacterial, viral and tubercular. Main important part is protein and glucose. Protein will be elevated in bacterial and tubercular. Will not be much elevated in viral. Glucose will be markedly low in bacterial. While in viral it will be normal, in tubercular it is low but not very low. Gram stain will be positive in bacterial. Jaden stain will be positive in case of tubercular. Jaden stain. While in viral, Jaden and gram stain will be negative. So this is an important clue. Usually we say that WBC count will be very high in bacterial, while in case of a tubercular, lymphocyte count will be high, but total count will be less, while this will be in thousands before treatment. So 90% polymorph, here mainly lymphocytes and monocytes, while in viral, 90% of that will be what we call as a monocytes. Good number of monocytes will be present. EEG will be helpful mainly in patient with epilepsy and to find out the severity of damage and brain death. CT scan is utmost important for intracranial pathology, and in some of the cases of what we call as the extracranial, which produces a damage because of say hypoxic damage, toxic damage, etc. Hypertension in those conditions. So either CT or MRI you can combine with angio or we call contrast. Lumbar puncture test is useful in presence of subarachnoid hemorrhage, intracranial hemorrhage and infection, and sometimes in case of inflammation also, rare conditions. Now once a person is settled down, now you have to go for a long-term care if a person does not recover as far as level of consciousness is concerned, in which you require a continuous respiratory maintenance, that is airway maintenance, monitoring, pulse oximeter monitoring, maintain patent airway by all the different mechanism. You can use the airway, you can use intubation depending upon the clinical condition, remove the what we call as an artificial denture, etc. Or you can even have a intubations, suction. If a person has already undergone tracheostomy, then care of tracheostomy. So maintain the patent airway, maintain ventilation and oxygen. Then cardiovascular, that is blood pressure and pulse should be maintained. Maintain nutrition and hydration, electrolytes. So nutrition should be maintained either by Ryle's tube or by IV fluids or by TPN, whatever way you want. Whatever is feasible for the hygienic care for skin, eye, oral cavity, bladder, bowel, all this, eye care, skin care. Don't allow the person to develop a pressure source, DVT care, regular movements, avoid DVT by giving anti-embolic stockings or by giving anticoagulants and regular movements. Complications, some of the complications are very common in an unconscious person, and particularly if he is a bedridden for long period. Aspiration pneumonias, atelectasis, chances of ARDS, lower respiratory tract infection, urinary tract infection, bad sores, DVT, pulmonary embolism, malnutrition, electrolyte imbalance, oral infection, particularly thrush, candidiasis, complications because of basic etiology, and later on because of a prolonged damage to cerebral cortex or to the brainstem. When there is a damage to the brainstem, locked-in syndrome, and if there is an extensive damage to the cerebral cortex and cerebral hemisphere, vegetative stage, and invariably they succumb to lead because mortality is very, very high. So skin complication, respiratory complication, cardiovascular complication, GI complication, urinary tract complications, skin, pressure sores, lacerations, respiratory, lower respiratory tract infections, pneumonias, embolisms, aspiration pneumonias, cardiovascular complication, DVT, postural hypotension, thromboembolism, pulmonary embolism, GI tract, paralytic ileus, constipation, distension, in urinary UTI, stones formation, musculoskeletal contracture, osteoporosis, dystrophy, weakness, foot drops, and if a person recovers good number of time, anxiety, depression, psychological disorders, etc. are common. Cognitive function improvement will be less. Full recovery will happen in very few patients with a severe brain damage, and invariably they go into a locked-in syndrome stage. Good number of people goes into a stage where there is a moderate to severe cognitive and motor disability. They will remain in a stage of minimal conscious stage, and then they become a persistent vegetative stage, and finally they become brain death syndrome. There are some factors which are responsible for prognosis. Say longer the duration of coma, the prognosis is poor. Lot number of comorbid conditions like diabetes, hypertension, cardiovascular disease, poor prognosis, malignancy, poor prognosis, old age, poor prognosis, newborn child, poor prognosis. At the prime stage, if a person has come in a cardiac arrest or person has come with a severe traumatic injury, etc., baseline functions are very poor, poor prognosis. And if the person is in a deep coma, Glasgow coma scale is not good, say 3 or less than 6, very poor prognosis. If it is a severe traumatic brain injury, massive hemorrhage, herniation has taken place, there is a tonsillar herniation, poor prognosis. And this you can find out by doing serum biomarkers. In near future, we might have some serum biomarkers for identifying the severity of the neurological damage, like we have got troponin, etc. Or we are having BNP for cardiovascular disorders. EEG will be helpful to find out the brain death or functioning part of the brain, or there is a status epilepticus, and neuroimaging is also of importance. All these three can give you a good or a bad prognosis. Idea regarding those. So there is a take-home message. Remember, clinical analysis of comatose patient is absolutely an urgency. First, always have vital data normal and try to maintain airway, breathing and circulation. History, good neurological examination, and then other system, that is cardiovascular, respiratory and alimentary system examination is helpful. Look for raised intracranial pressure signs, brainstem reflexes. Look for herniation signs and also look for progress. Have a rapid and systemic examination followed by investigations and prompt therapy. Even before the history and examination is done, if possible, always give glucose. Have a blood sugar examination and give glucose and oxygen and try to maintain a blood pressure. If there is a shock stage, vasopressure, IV fluids. Maintain oxygenation and have a IVSS. Give glucose, thiamine if you are suspecting alcoholic person and wernicke's encephalopathy. If you are suspecting benzodiazepine overdose, give flumazenil. If you are suspecting person is having a opium poisoning, give naloxone. If person is having a very bad respiration, you can go for intubation or even for tracheostomy. If a person is having a cervical spine injury, stabilization. And if you are suspecting extracranial pathophysiology, then go for all big list of investigations. Keep your head cool, never get panic. If you don't get panic, you will have lot of things to investigate and examine the person and you can save the life. I end my lecture here. I hope this lecture will be very helpful to you, particularly the person who are working in an ICU or emergency ward, and you will see lot of times this particular group of people in your everyday practice. So I end my lecture here.